You are currently the only person in this conference.
Your learning outcomes for this chapter will be to talk about the major principles and concepts of atraumatic care, incorporate atraumatic care to prevent physical and or to minimize stress and for children and families, discuss major components, concepts of family-centered care, utilize therapeutic communication skills when interacting with children, utilize culturally competent communication, and then describe some of the processes of health teaching. There's your Pima course outcomes. So what is atraumatic care? We talk a lot in the pediatric world about an ouchless ER, and that's kind of the goal someday. Kids should not have to be subjected to painful procedures without some type of care, explanations. You really want to minimize that distress. So atraumatic care, according to your the book, is that it's therapeutic care that minimizes or eliminates the psychological and physical distress experienced by children and their families in the healthcare system. So what does that mean? So it goes under that whole concept of do no harm for the medical profession. As pediatric nurses, we need to be very aware of our patients and be advocates for them. I've been involved in situations where physicians were doing a procedure or something and they had medicated the child or given me orders to medicate, and the pain medication is not adequate, and you can tell. You really need to be that advocate and say, do you think we could give him more pain medication, things like that. I once had a patient who was 14 that arrived via ambulance, and he had a open fracture, which means the bones were sticking out of his leg. It was a bad quad accident, and he had been given no pain medication en route. He came from an outlying area with paramedics in an ambulance who have standing orders for pain medication, but did not give him any. They put an IV in case he needed any, but they never gave him any medication. And so sometimes it's a fear of medicating kids. We all should have that fear because most kids are are naive to any type of narcotics. So really education is what's needed, that this kid needed pain medication badly. I mean, I can't even imagine having a bone sticking out of my leg and having a long time to the hospital, all those bumps and things like that. So we're the advocates. We need to, speak up. We need to look at the stressors. You really want to minimize the separation from the family. So after you determine who is the family, you want to be able to allow them to stay. So if there's a large family, you want them to be able to come in and out and change places. But there's no, typically if I'm not doing a procedure, I don't mind if, 4 or 5 family members are in there. That's what that child needs at that time. You want to provide teaching in a way where the family and patients don't lose that sense of control, help them cope with different situations. And so we talk a little bit about age appropriate. So using an iPad to distract, using stickers, cartoons, child specific. So you want to talk in their language, and we'll talk a little bit about that. Therapeutic play. So therapeutic play are situations where they can, it's goal directed, and they can act out situations or draw out situations. There's these gauze dolls that they'll give kids to draw where they were hurt, things like that. Some principles in box 30.1 is it's just some the principles of what we're talking about basically. So child life specialists. So I think I mentioned them before, but child life specialists, they're trained. They have a 4-year degree in some type of family, child psychology, things like that. They go on to do about a 600-hour internship and then take a certification exam, not unlike your NCLEX. So their 600-hour preceptorship they do with another child life specialist. And now I think the level that they're hitting for soon is a master's level. Right now it's a bachelor's level. Um, so they are just wonderful people that really help you do your job as a pediatric nurse. Um, so their goal is to decrease the anxiety, they talk about normalization, so making the hospital a more normal place to be. Um, so they involve play. They help prepare children for tests, surgeries, any type of other medical procedures. They are housed in the OR, in pre-op, in radiology, where they're doing some interventional radiology um, procedures, and then in all the pediatric floors, and then in the pediatric ER. They will prepare the child for a procedure. They usually have a bag of toys and tricks that they help with that. They have an iPad. Um, they will support that child during the procedure, talk them through it. They, like I said, use therapeutic play. They support siblings, and they do a lot of advocacy for the child. They work with the grief and bereavement support groups. They'll do emergency interventions, hospital pre-admission tours, informational programs. They also do set up activities like having the cheerleaders come or the basketball team come from the U of A. Wilbur and Wilma come over and visit. They have therapeutic ponies. They have therapeutic dogs. They have a lot of resources at Halloween time. They set up for the Spirit Halloween store to deliver free costumes to the kids who are in the hospital. During Christmas, they arrange for Santa to come. They also have at Banner, they would have a Christmas shop where kids could come and shop for free for their families if they had to be hospitalized. According to the American Academy of Pediatrics, they said that child life services is an essential component of quality pediatric health care and are integral to family-centered care. And it's the best practice model. You'll hear kids, if they've been a patient before, ask for the child life specialist. Now in Tucson, only Tucson Medical Center and Banner have child life specialists. The other hospitals, because they're not pediatric specific, do not have the luxury of having them. Another thing that they do is help prepare children if their parents have been in an accident, if their sibling has been in an accident, if their parent has died. They help with that type of preparation. They, if they'll take a child into ICU, if their parent is in ICU, and before they go, they prepare them of what they're going to see, hear, smell, because there's smells all over the hospitals. And then those machines that are beeping, they prepare them with that and they work through it. So they wear a lot of hats. They are invaluable, in my opinion, in the ER, and they're very good at working as part of the team. So this is just a thing, just saying what they are. They're not babysitters. They are really there to help normalize the situation. So when we're going to do any kind of procedure, we want to minimize stress. And so it's already stressful coming into the hospital, but you'll notice when we go to clinical that the units are very child-friendly. So decrease their anxiety and stress, and one of the ways that we do it is preparation. So we like to use what's called, your book calls them therapeutic hugging. I call them comfort holds. And so it's the different holds that a parent can do to help out. You have to have a willing parent, of course, but if they're giving their child a hug while you're doing a procedure, they just seem to really handle it better. At the same time, they'll be doing some distraction, which really helps too. Family-centered care is really what guides our practice. If we don't have the family support in a child's care, then that child's not going to be successful in the treatment and care and when they go home. So because kids are really somebody else is doing their care and they're relying on that, we have to include them in the care. So it's a partnership. On the floors at the hospitals at TMC and Banner, they have what they call care rounds in the morning. And so the physician, the residents who are on the case, the nurse, and anybody else that needs to be there, like nutrition or pharmacology, pharmacist or something. And what happens is the nurse gets report from the night nurse, and then she shares what happened overnight with the team. Also on that team is the parents are included because they're an integral part of that whole care of that child. And so they go from room to room discussing the case, any problems, discharge plans, all that kind of stuff. So everybody's on the same page, and especially the parents. When we talk about family-centered care, it really works well when it's done correctly, especially for kids who are chronically or terminally ill, or a kid with a new diagnosis of a chronic or terminal illness. There's a lot of education that goes into the care before the parents take the patient home. The family is the constant support in the child's life, and that's primary source. So we need to really encourage that type of relationship. So respect for the child and the family. When you think about it, if you have a child with a chronic illness, often the parents are experts in that field. Once their child's diagnosed with something, they, really research and really understand what's going on. And they're taking care of that patient 24 hours a day, 7 days a week. So they get to know the care, the specifics of the patient. When they come in the hospital, sure, we, nurses and doctors have gone to school and have training, but we're not there taking care of them 24 hours a day. So really asking them, how do you do this? How do you give him his medicines? What is his tube feeding? What do you flush it with? There's all kinds of questions you have. And it's good to respect that information that they have. Now, there's a fine line between them having knowledge and another parent or family member reading, Dr. Google and figure things out. But kids with chronic illnesses, parents typically are very schooled in their care. As far as identification, we want to also respect recognition. So recognize cultural, racial, ethnic, socioeconomic diversity. We really aren't there to judge anybody. We're there to take care of the patient. So if we need to assist them with resources, we can do that. Your social worker is a great resource for that. Identification of the family and their strengths. So identifying that and then working on the barriers they might have. Supporting them. Again, it's their choice. It's their child, their family member, so they have the ultimate decision. But giving them all the information they need to make those decisions. So flexibility. Again, I see this with the chronic kids. Maybe we think that they should have their medication at a certain time because that's what the hospital says. Yet what works for them at home is this time. So we need to be flexible. Honest, so provision of honest, unbiased information. They want to know the truth, and that's really important. Not only giving them that information, but listening to them too. Assistance with anything that they need. Again, we have resources. There's always a hospital chaplain if that's something that they want. Collaboration with them, that goes back to those care rounds that they're doing. And then a big part of it is empowerment. If we don't give the families the tools that they need to take care of this child successfully, then the child's just going to be back in the hospital. Parents will get frustrated, things like that. So really being mindful of giving them the tools and letting them do the care. I'm going to go back just to page 30, page 2, table 30, page 2, 30.2, page 1116, sorry. And there are some terms to avoid as kids can misunderstand certain terms. Like a catheter that doesn't mean anything to them. You can use a tube. Deaden, we're going to deaden the skin. Well, they think kill. So you want to say, we'll make the skin sleepy or something like that. One of the biggest experiences I had a kid and I told the mom he's going to go over to CAT scan and blah, blah, blah. And he came back crying because he didn't see any cats over there. So really make sure that your words match the intentions. You want to simplify words, but not dumb them down so they don't understand. Um, Communication. So communication is huge too. Some parents don't know how to advocate or speak up for their child, so sometimes we have to pull them out, asking them things. Most of the time, people feel a sense of loss of control when you go in the hospital. So they don't. We know what we're doing, but they don't know what they're doing. What we're doing. Um, so effective communication really helps smooth that hospitalization and and making sure that they truly understand, giving them time to reflect, time to ask questions. Use verbal and nonverbal. You go in a room and have your hand on your hip, that's nonverbal communication saying, what do you want? I don't have time for this. So they're going to pick up on things like that. Using developmental techniques when communicating with kids. So we'll talk a little bit about that. Again, certain phrases we want to steer away from. Always honest answers and communicate directly with the child if they're old enough. That really is important. Sit down on their bed, get at their eye level. I know you learned that you don't sit on beds, but we do in the peds world. Assist the family. Like I said, there's tons of resources. Maybe it's a support group for a new diabetic or asthma, things like that. Again, clear, concise information directly with the patient and give the truth. So for infants, we want to really communicate through touch, sight, and hearing. Um, they respond best to those. Toddlers, you want to give them time to complete their sentences or complete their thoughts. The school age, give them simple, honest answers. Like I said, give them a little job to do. They're very straightforward and they're very eager. And when they get to the older school age, they really can understand a lot of the information. So give it, give it as they need. And then adolescents are the open-ended questions. Don't ask yes or no questions because you're likely going to get a no or maybe even a grunt. But you want to really open up that communication with those open-ended questions, direct. Again, don't treat them like they're an adult just because they may look like one. Really find out where they're coming from, what's going on. A lot of times they act very macho, but it's because they're scared. Family, again, honest, understand their value. Like I said, these kids with congenital problems, it's huge what they know. And the best of the doctors I've worked with have gone in and said, I understand your child's here. What is it that you want? And it's not that they're not being sarcastic at all, but kid comes in on a ventilator and the families, will say, oh, well, they're just very congested. I think he needs a chest x-ray. And they value that. They appreciate that and respect their knowledge. It's always amazing to me when I sit and talk to a family member of a chronic child and what they know and what they've done and all this research and how they advocate for their patients and insurance-wise and things like that. To me, it's just amazing. And then give them time to absorb, especially if you're giving a less than favorable diagnosis, if a physician is. The visual, what they'll look like. They're going to go to the CAT scan and they'll be on a bed, but they'll have a big tube that their head will go in. And then be aware of the literacy level. So we're going to talk about that on another slide, but that's really important. One of the HP 2020 goals is to increase the proportion of persons who report that their physicians have satisfactory communication skills, and then improve the health literacy of the population. I thought that was really interesting that's one of the goals is for physicians to be better at communicating. I think nurses are good at communicating. I think physicians are not trained the way we are. So we need to be aware of that. Adults are self-directed, so don't treat a parent as being, not knowing what's going on. They're task-oriented, and they want their needs satisfied. So They want, if their child's sick, they want someone in there right now. They want the care to start. So, and they do, reflect on their past experiences. So goals is to improve the family literacy that I talked about, communication, health outcomes, so promoting healthy lifestyles. This comes into play sometimes when we have kids with asthma who come into the hospital with an asthma exacerbation and the parents still smoke. So that's really a problem. And so we have to do a lot of education there. Same with diet. I had a kid who was I think he was about 5 or 6 years old, and he weighed probably 40 pounds more than he should. When speaking with the father, he said, well, I have 4 kids. I'm trying to support them, and most of the time we just do tacos from Jack in the Box because they're 2 for $1. So not a lot of nutrition there. And then so sometimes we just have to give them some resources. So he probably could, I don't know, but I referred him to our social worker who gave him information on food stamps and WIC and things like that. So encouraging involvement, that's huge too, because like I said, if the parents aren't involved, then the care is not going to happen. Compliance, here we go. This is one of the things that we, as nurses, get frustrated with, at least I do, is the compliance. It's one thing to not understand something, but it's another thing to just not do what you're supposed to do. So sometimes it takes a lot of education to get them on that treatment plan and stay with it. And then promote that sense of autonomy and control, because they, like I said, they'll be the ones caring for the patient. Just some red flags indicating poor literacy skills. So they have problems filling out forms, they miss appointments, they're non-compliant, medication errors, say things like, forgot my glasses, I'll read this when I get home. They won't answer questions. They avoid asking questions for fear they look stupid. I think still the average age for adult literacy is around 7th, 8th grade. So we don't want to use big terms. We want to explain that in their language. And we're very used to speaking the language of nursing. And we have to remember that not everybody understands what we're saying. So really trying to assess that. Now, there's no way you can go up and ask, can you read or not? But there's ways that you could give them something simple to read and see if that helps. Otherwise, you do verbal and have them, just sit down with them, get on their level. When you build a trusting relationship with your patients and your families, often they will let you know, oh, I can't read this, I can't afford this medication, things like that. So it's all about that trusting relationship. Teaching adolescents and children. So remember, preschoolers are magical thinkers. So they have vivid imaginations. They make false assumptions because they learn bits of information. They're skillful. They're timely. They have, you want to think about all the senses when you're talking to them. When you flush a saline lock with saline, some people taste it. They taste the salty taste in their mouth. So you want to let them know, because that could freak them out if they didn't know that. School age, they like to participate, cooperative, and they appreciate direct speech. And then adolescents, they're abstract thinkers. They're very sensitive, especially their body image. Getting dressed in a gown is maybe something that they don't want to do. Often they will be stoic and they won't give you all their pain scale, because they know, oh, I'm going to get an IV and things like that. So you have to use a lot of your assessment skills on this age. So cultural assessments, again, there's many different practices, and you want to just kind of find out about what's going on. So you may ask questions like this, maybe not necessarily these questions, but you want to ascertain how their practice works and their culture. So you can see if it is aligning with the goals of the physician and the treatment team. Okay.